Hello, my name is Michelle Meltzer. I am an Associate Clinical Professor of Medicine at Thomas Jefferson University Hospital, and I am a rheumatologist. The reason I'm here today is, as a rheumatologist, I see many patients who come in with gout, and unfortunately a lot of them are mismanaged and have a great deal of suffering with it. They also lose a lot of time for work. And I hope today to introduce you, to help you understand the patient's script or the patient's story, to introduce you into how I do a physical examination and to show you some physical findings on gout. And then I'm also going to discuss the pathogenesis of gout, diagnostic studies, treatment and prevention, and lastly, but equally important, is counsel to patients, because a well-informed patient is going to understand what they need to do. I want to thank Mr. V for coming here today, and the reason I have him here is to illustrate not only how to make a diagnosis of gout, but the process of how I got there. And this really begins in how we approach someone who has arthritis. So I'm going to start by asking Mr. V what brought him to my office in the first place.
I had started getting multiple swelling in multiple joints, and I wasn't sure what was going on. I went to my family doctor, and he highly recommended that I go to see a rheumatologist.
Okay, and tell me, how old were you when you first started having attacks of arthritis?
In hindsight, I was about 16. I wasn't sure. I thought maybe I had a sports injury or something like that.
And what happened, let's say the first time it happened, what happened?
I woke up in the middle of the night. I had this swelling in one of my big toes.
Right.
And it was just painful. I couldn't even put a blanket over it.
Okay, and then you went, did you seek medical care?
I spoke to my parents about it. My dad, he has gout.
Right.
And he just told me, hey, it is what it is, and, you know, just rest.
Okay.
Okay.
And then when was the next time this happened?
It's probably maybe within a year.
So within a year you had your second attack?
Yes.
So you were 17 then?
17, and then it became more frequent, and in college it became more frequent, and the past few years it's just maybe every month, multiple times a month.
Okay, and is this affecting your life now?
It is. At first it was something that happened, then it went away, no lasting impressions, but now there's very few things that I could do that I was able to do.
Okay, so that's good. Okay, so we've gotten a nice history, and I'm going to review the nuances of this at the end. I'd like to discuss the epidemiology of gout. It's been changing over the past few years, and we feel that this is in part because of lifestyle. But traditionally we thought of gout as a disease that occurred in middle-aged men. Women develop gout when they're postmenopausal. But with the epidemic of obesity, we're seeing gout in younger and younger people. Now, Mr. V is much younger than the average person that I would see, so I would want to know more about his family history or any genetic problems. We're also seeing an increase in gout because of some of the medications that people take. People who are on diuretics have an increase in uric acid, and some of the transplant medicines can also cause hyperuricemia. There are certain ethnic groups that have a higher incidence of gout as well. We know that the Maoris, which is the tribal group in New Zealand, had increased amount of gout compared to the baseline population, but with changes in lifestyle have had even a more remarkable increase in the incidence of gout. I know that many of you are international, and I invite you to look in your own communities, because there's so much about the epidemiology and the incidence of gout that we don't know. Mr. V is of Vietnamese origin, and I did research and could not find any information to know if he's at increased risk for having gout or not. Next, we're going to discuss the time course of the arthritis. Mr. V's arthritis was characterized by acute episodes of arthritis that recurred over time and eventually became chronic. This is typical of gout. The next thing I do is I make a syndrome statement. We have a 25-year-old male with a history of recurrent episodes of gout that become more frequent in time. It's important when making a syndrome statement to compare it and contrast it with other diseases. In this case, we have a young man, and we might want to compare his arthritis with inflammatory bowel disease or reactive arthritis. And it's important to have more than one disease entity so that you can make a differential diagnosis and not get stuck in one way of thinking. While doing this, it's important to have an idea of the patient's other medical history, such as diarrhea, or back pain or skin rash that might happen in reactive arthritis. And I also encourage you, when you're starting to make a differential diagnosis, to disregard diagnoses that have been given to you, to the patient, by previous physicians. And now we need to know about the past medical history. And as I'm asking or commenting on different parts of the past medical history, I want you to think about, why am I asking these questions? So one of the questions that I have for you is, are you aware of any problems with your kidneys?
As of right now, no.
But you had an episode.
I went to the emergency room not too long ago. I was having these back pains, and I couldn't lay on my back, my side, and I went to the emergency room. There was blood in my urine.
And what did they tell you?
No one knew what was going on, and they sent me home.
Okay, so again, I want everyone in the audience to think about this. Why did he have blood in his urine, and why did he have the back pain? High blood pressure.
I had high blood pressure in the emergency room, but I thought it was from the pain, and usually, when you're in pain, your blood pressure shoots through the roof.
So usually you don't have, your blood pressure is usually normal?
Yes.
Okay. Any problems with skin rash?
Not that I know of, no.
Chronic diarrhea?
No.
And diabetes? Or is this running your
my dad has diabetes.
And how about elevated cholesterol?
High cholesterol as well.
Runs in your family?
Yes.
Okay. And you're certainly, obesity, does that run in?
No, it
okay.
does not.
And medications. Other than medications, which I recently gave you, have you been taking any medications?
Only when I've had some swollen joints, just some ibuprofen.
Okay. Okay, social history. Do you drink beer?
I do.
And how much beer would you say you drink?
I would drink once or twice a week.
And how many at a time?
No more than 3 at a time, and that's rare.
Okay, so this is not a high beer intake. And how fructose, I'm going to ask, is sweetened beverages like sodas. Do you drink sodas?
I used to, not so much in the past recent years.
Okay, and how about meat? Do you eat meat daily, or?
I do eat meat daily, but I eat veggies, a lot of veggies and fruits.
Okay, now not in the United States, but in many parts of the world, lead exposure is very important risk factor for gout. So the way you would be exposed would be old houses that have paint. You have been exposed.
No, I'm familiar with what you're talking about.
Okay, and then the other is, I'm not sure about certain parts of the world, but I know in the United States, when we used to make moonshine or homemade liquor, they would use pipes that had lead in them, and so there was a whole rash of renal dysfunction and gout related to lead exposure. So I just invite people from different parts of the world to see if that's an issue where you live. And we already went over how the episodes of arthritis have had an impact on your life. And just give us an idea, if you were to describe the pain, How bad?
I haven't ran in maybe 2 years.
So you were a runner, and you. Okay.
I was a runner. I played basketball in high school. Can't do that anymore. Opening up a water bottle is difficult.
Okay, so this is somebody who's 25 years old, and you can see how the disability is already starting, but we're going to get rid of it. Okay, we discussed your family history already, and you said that your father and...
Both of my grandfathers had it.
Okay, uncles, aunts?
Uncles, not all of them, but I have about 10 uncles.
Okay, so you have a very strong family history.
Yes.
And how about other forms of arthritis? Are you aware of any other types of arthritis
Not in my family, no.
Okay. Okay, so now I'm going to demonstrate how to do a joint examination, and we'll start, usually I start with the hands. So I start over with the hands, and I look closely to see if there's any muscle wasting, to see if there's any deformities, and then I start over, these are the metacarpal phalangeal joints, and I press hard enough to blanch about a third of my thumb, and then when I come over here to the middle finger, I've already come up with an abnormality. And if you can see, there's some swelling over here, and when I touch this joint, it's firm with a little cystic, and I also, as I go to the, this is the PIP, the proximal interphalangeal joint, there's also a little bit of swelling, or a little bit of kind of hard swelling, and I check the MCPs of the ring and the fifth finger are normal. And then the PIP joint of his index finger is also abnormal. There's a little bit of bony enlargement, and the other PIPs are normal. And these are the DIP joints, or the distal interphalangeal joints, and they're normal. And then what I do is I flex his fingers, and this is so sad, is look, he already has lost some flexion of his index finger. And this is important. Well, I don't have to tell you, your right hand, your index finger, if you can't flex, it's problematic. And he's lost some ability to flex the middle finger. The wrist is normal. And then when I come to his elbow, I see there's a protuberance over here, which is firm. And there's also over his elbow. So this is a tophus. These are tophi, which are deposits of uric acid in the skin. Then I take the shoulder, I abduct it, I externally and internally rotate it, and his shoulder is normal. I go back and I look at his neck, and I have you put your chin on your chest, bring your head up all the way, your neck all the way back, and then your chin over to one side all the way, and then to the other. And that's normal. And then I go to the left hand and I do a similar thing as I press with about a third of my thumb. And I also here, not as much as on the right hand, but again you can see there's some swelling over here, and he's also lost some flexion of the MCP joint of his left middle finger. This PIP joint also has a little bony enlargement. The other ones are okay, and the DIP joints are fine. And when I have him make a grip, oh, I'm sorry, I didn't mean to hurt you. But again, you can see there is some abnormality of flexion, but it's not as severe as it is on the left side. The wrist is fine, and I go here. And what we have here is another tophus. The shoulder is fine. And then I'm going to have Mr. V lie down. I'll put this so it gives protection. Okay, just lie down. And I'm going to pull up over here. And when I look at his knees, in a normal knee, you should see a little concavity here if there's no fluid. And I can also see, if you compare the two knees, this knee is normal over here, but you can see there's some swelling on his left knee. I see it. Can you see this? This is called a positive bulge sign. And that tells me that there's some fluid in this knee. And then I flex the knee and I externally rotate it so his hip is fine. And then I go down and I look at the ankle is okay. And he has some bony enlargement over here over the great toe, over the first metatarsal phalangeal joint. And I can't tell if this is a tophus or some arthritis. And the left knee, as you can see, does have some swelling. It has so much swelling that I can't get the positive bulge sign that I was able to demonstrate on this side. And you can see that there's some lines over here, and this is because Mr. V has been taping his knee, and he got an abnormal suntan. And it's just to show you how much this is bothering him. Then I flex, and even the flexion of the knee is not completely full, and this is probably because he has fluid. I externally rotate the hip, and it's fine. The ankle is okay. And then even when I look at this foot, there's some swelling over over this toe, and again some bony enlargement here. So what I can do is I can aspirate some fluid and just see what it looks like. Okay, so I've discussed, for the sake of brevity, I didn't go through the informed consent, but I did tell Mr. V what I'm going to do. And what I'm going to do is first I take betadine, I feel where the fluid is, and I clean the knee, and then I take my syringe and I take some ethyl chloride, and that's just to freeze up his skin, just so it doesn't hurt. And then I take the needle and I go right into the joint, and you can see there's lots and lots of fluid.
Move your left hand a bit.
Okay, that's it. Okay, and that's it. Okay, and what you can see is I got a fair amount of fluid. I don't know if you can pick it out on the camera, but there's a few little white flecks in here. And if I were to put this under the microscope, I'll show you what it looks like. But this is typical of what you would see in gout. Sometimes it can be even cloudier than this. And tell them how much better it feels to get this off your knee.
It feels amazing.
Okay, thank you. Every patient comes in with a story, and we call this a patient illness script. And we need this script to help us come up with the correct diagnosis. So we start with the epidemiology, and I didn't even give you Mr. V's age, but he's a 25-year-old male. He's of Vietnamese descent. I don't know if that's relevant to the case or not, who has a strong family history for gout. And then the next thing we do is we look at the time course of his complaints. Now, this can be relevant to any disease, but we're looking towards arthritis. So people who have one episode of arthritis, my thinking is going to be different than someone who has recurrent. So he gives us a history of recurrent episodes of severe arthritis that over the course of years became more frequent in time, yes, and more severe, and got to the point where he was having persistent pain.
Yes, correct.
Okay, so what I then do is I summarize this in a sentence, which we call a syndrome statement. And this is just to help me think about, or to summarize what his complaints are, so and the next slide you'll see, so I can compare it and contrast it to other illnesses, other causes of arthritis. And also, I'm thinking about the mechanism of disease, and this would be whether it's infectious, autoimmune, or in this case, crystal-induced. So I would summarize by saying that we have a 25-year-old male who has a strong family history of gout, who has acute episodes of arthritis starting in the great toe. And this is obviously very suggestive of gout. So what we do is we take his illness script and I compare it and contrast it with other disease scripts. I do this so that, one, I don't get locked into one line of thinking, because if he walks in and I say, okay, it must be gout, then I might miss something else. In certain parts of the world, not as much so in the United States, tuberculosis can give a chronic arthritis that usually doesn't have acute episodes. Of course, sepsis can give an acute episode of arthritis and must be considered, but it's not going to be chronic. I'm not going to go into the nuances of the other diseases in the differential diagnosis, but I invite you to read about them. And of course, rheumatoid arthritis would be the differential, because Mr. B is a male, a young male, but not exclusively in young males, a reactive arthritis, or seronegative arthritis, inflammatory bowel disease. That's why I was asking about diarrhea, psoriatic arthritis, and even hepatitis. His clinical presentation, as you compare and contrast to these other diseases, has some things in common, but not enough in common for you to make a different diagnosis. Again, the time course is suggestive of gout, and the mechanism is crystal deposition. So, the reason that I am doing all of this is, why did it take 7 years? And look at the suffering. And I want you to give, what do you think?
When I started getting the attacks at a younger age, it was kind of, for me, I brushed it over, because after a few weeks, things would just get better. And as I got older, things wouldn't get better. And then I started seeing doctors, and they passed me on to specialists, and they wasn't sure what was going on. And
why weren't they? What kind of specialists did you see?
I went to see a rheumatologist
okay.
a few years ago, and he came into the room, looked at me, and said, "It's probably gout," and said, "Come back in 2 weeks." And I took it as a slap in the face, like, oh, okay, I took the time out of my day to come see you, and he wouldn't answer any of my questions, and that was it. And I was kind of fed up after that. And it was like, okay, forget this.
Okay. So this is important. I want everyone to hear this, because it's our obligation to tell our patients how serious gout can be, because part of the problem, in my own opinion, is on physicians, and if the patients blow it off, then I think it's our fault too. And I want to thank you so much for coming here today.
It's my pleasure.
And thank you.
Okay.
I want all of you to remember what Mr. V said about how the diagnosis of gout was not made. There were several opportunities. He did see physicians, and they didn't seem to take it seriously because, or his complaints, because he was so young. His own family, which suffered from gout, didn't take it seriously and didn't push him to seek medical attention. But what I find even more disconcerting is that he went to the emergency room at a hospital in Philadelphia only a few months prior to coming to see me. He came in with flank pain and blood in his urine. He had the tophi, and again, nothing was done, and no one took him seriously. So I encourage all of you, is if someone comes in with joint pain, to listen, make a differential diagnosis, compare and contrast as I discussed, and try to prevent the story that you just heard from happening.